My name is Lily Doe. I am a fourth year medical student, and today I wanted to discuss a little bit more about oppositional defiant disorder and conduct disorder. In today's presentation, I will be focusing on the understanding of the diagnostic criteria, clinical presentation, as well as a little bit on management and treatment. And towards the end of this presentation, I plan on doing just a really quick case presentation to try to tie everything together. So let's get started. So this slide is just demonstrating the outline for my presentation today, starting with just a quick introduction on what oppositional defiant disorder is and conduct disorder, with the clinical presentations as well as management, treatment strategies, as I had said at the beginning. And I will try my best not to just read directly from the slide, just to offer just a little bit more with this presentation. And I also will be discussing a little bit about some of the changes that were made to the most recent DSM-5 that was published in 2022. Now, some commonalities that are shared between oppositional defiant disorder and conduct disorder is that they both are a type of disruptive behavioral disorder. They're primarily found or diagnosed in children and adolescents. With oppositional defiant disorder, it is characterized by chronic features of irritability, argumentative behaviors, whereas conduct disorder is kind of a more severe progression of oppositional defiant disorder from what is often seen in clinic. With conduct disorder, you see a lot more aggressive behaviors, destruction of property, deceit, and rule violations. With conduct disorder, the children and adolescents diagnosed with it, they commonly exhibit behaviors that kind of go out of the realm of societal norms. So sometimes we are told, it's wrong to set fires, and we know as children that it's not right to play with fires, it's not right to set them, it's not right to harm other people, kind of pushing or bullying or things like that. And for children and adolescents diagnosed with conduct disorder, they kind of do everything that society tells them not to do, almost like it's some type of impulse for them. It is very important to have some early recognition for effective treatment and intervention to prevent long-term consequences for these patients. Now, starting off with oppositional defiant disorder, according to DSM-5, a child is diagnosed with this if they exhibit at least 4 symptoms from the following categories, as you can see here in the presentation, that last for about 6 months. These behaviors can cause quite a lot of distress or interfere with functioning in social and academic setting. The diagnostic criteria for oppositional defiant disorder include an enduring pattern of angry and irritable mood, argumentative behaviors, or vindictiveness. The symptoms must occur more frequently than what is developmentally appropriate and must be observable in interactions with at least one individual who is not a sibling. So when you're taking the child to see their family practitioner, or maybe they're seeing a psychiatrist, a therapist, and these people that interact with them outside of the family are also able to kind of see these behaviors in the child. And also, as you are developing in your childhood years, the occasional temper tantrum is normal. So you're really wanting to observe the child to see, kind of finding those abnormal temper tantrums to really hone in on the diagnosis. It's very important to get a thorough patient history when trying to diagnose a child with oppositional defiant disorder. The behaviors must cause significant impairment in social, educational, or occupational functioning. It's critical to kind of assess the living environment that the child is in. How are mom and dad at home? How do they interact with their siblings? How do they interact with friends at school in the academic setting? What are parenting styles like? What are some environmental exposures that they have in the home? Are they coming from a safe home, an abusive home? It's very important to kind of take a history from not only the child, if they're able to, but from the parents. It really is about kind of bringing in the entire community and helping children who are kind of thought to have oppositional defiant disorders, talking to the teachers, getting a sense of how they act outside of the home as well. When it comes to oppositional defiant disorder, you can also characterize it with mild, moderate, or severe. Mild symptoms are kind of confined only to one setting. So little Timmy could be only presenting symptoms at home or only presenting symptoms at school. But when they're in another environment, they're completely normal, as you would say. I don't particularly like using the word normal, but they're not showing as many symptoms or fitting the criteria for oppositional defiant disorder. For moderate, some symptoms are present in at least two settings, so home and school. And then for a severe diagnosis of oppositional defiant disorder, symptoms are present in 3 or more settings. So kind of any environment that they are in, the doctor's office, home, school, church, wherever they are kind of constantly showing the symptoms to meet the criteria for oppositional defiant disorder. So for conduct disorder, as I have kind of mentioned earlier on, it kind of are more severe patterns of oppositional defiant disorder. So kind of persistent behaviors of violating societal norms with at least 3 symptoms in the past 12 months and 1 symptom in the past 6 months. Conduct disorder kind of involves that repetitive, persistent behaviors that violate societal norms or the rights of others. Kind of includes aggression towards people or animals, even destruction of property, deceitfulness, theft, serious violations of rules like truancy or running away. These symptoms, as you can imagine, causes pretty significant impairment in social, academic, or occupational functioning. And it must be attributable. It must not be attributable to another psychiatric disorder. So again, it's very important to take that history, kind of doing a differential diagnosis and making sure that could this be from anxiety? Could this be from depression? Could this be from another psychiatric disorder? You really have to hone in on seeing how the patient is presenting, what they have to say, what parents have to say, what their teachers in their academic settings, what their observations are, to really hone in on the diagnosis and be able to provide appropriate treatments. It's very important to kind of assess for any comorbid conditions. Some comorbid conditions that could exist with conduct disorders, things like ADHD or substance abuse. So for any children or adolescents that are being evaluated for conduct disorder, especially if they're in like their teenage years, it's important to kind of try to evaluate your patient one-on-one, alone, with the parents outside the house, kind of prompting those initial questions of, are you using any type of illicit drugs? Are you starting drinking or anything like that? Because you really want to get to the root of the problem if that is the case. If not, then you kind of tailor your questions towards the patient. With both oppositional defiant disorder and conduct disorder, the treatment plan is really tailored to the patient. You really have to get to know them, know how they react to certain situations, what works for them, because like anything else, one treatment plan is not going to work for everybody. And it's very important, especially in children and adolescents, to be able to show that you're willing to work with them, to get them to open up to you more as the provider for the patient. With conduct disorder, there are different types that you can go into, which have been some of the changes in the most recent DSM-5 TR, which is the childhood onset and adolescent onset. And that kind of just is based on the age of presentation. So if the patient is showing symptoms and it's before the age of 10, and that's your childhood onset. If it's after the age of 10 and they didn't show any symptoms at all beforehand, it's the adolescent onset. Just like oppositional defiant disorder, you can categorize it into mild, moderate, severe. Mild is just a few conduct problems in excess of those required to make the diagnosis are present, and conduct problems cause relatively minor harm to others. So lying, skipping school, skipping classes, kind of staying out after dark. Moderate, on the other hand, is a number of conduct problems, and the effect on others are intermediate to severe, whereas severe is like you have a lot of conduct disorders, conduct problems in excess, and it causes harm to others. So kind of like anything physical, getting into physical fights, using weapons. And again, this doesn't just mean to people, to humans. This could be also showing harm to animals. That's how some adolescents or children can kind of show symptoms of conduct disorder. And now kind of going to the clinical presentations. A lot of this is going to be kind of showing a lot of overlapping features between oppositional defiant disorder and conduct disorder. With oppositional defiance disorder, there is kind of that boundary where it's not crossing a line into something like breaking criminal law or breaking societal norms. Whereas with conduct disorder, you're more looking at things that are crossing boundaries, that are crossing lines, whether that's law, crossing boundaries with the law, crossing personal boundaries with other people. Oppositional defiant disorder typically presents with behaviors directed towards people of authority, having frequent temper tantrums outside of developmental norms, and increased irritability. These behaviors don't really involve significant violations to the rights of others, whereas conduct disorder does. Conduct disorder, you're going to see a lot more lying and stealing, destruction of property. If it's severe conduct disorder, you could see more physical aspects to it. The patient could be starting fights, getting into fights that aren't necessary. A lot of physical fighting is not necessary, but you'll see some adolescents kind of getting into a lot of fights with severe conduct disorder. Understanding the distinction between conduct disorder and oppositional disorder is fairly vital, because if the patient has conduct disorder and is not being treated, it could lead to even more harmful effects down the line into their adulthood, to where now they're getting in a lot more trouble with the law as adults. So being able to kind of catch those symptoms, being very keen on how your patient is presenting to you, can really help you narrow down how to diagnose the patient and the treatment plan that you want to do for them. We've kind of touched on this throughout this presentation, but just to kind of reiterate on, if you have a patient and their family presenting to your clinic, how to begin your initial evaluation. And the most important thing to remember is talk to your patients, communicate with them, really get a very thorough history from them if you can. You want to get a detailed history from multiple sources, so not just from the child, from the patient themselves. You want to talk to parents, siblings, teachers, if you're able to get a better understanding of how patients are outside of that clinical setting. How are they at home? How are they at school? How do they differ from each other? You can use validated screening tools with a patient to kind of help narrow down how the patient is. Some of these screening tools include the Strengths and Difficulties questionnaire or the Child Behavior Checklist to help quantify symptoms a little bit more. You want to assess for environmental factors like family dysfunctions. Do mom and dad fight at home a lot? Trauma, has the child been a part of any type of traumatic event firsthand? Have they seen a traumatic event? Sometimes that can also be how they present these symptoms, is that it's their coping mechanism, and that's something that you have to figure out and get down to the root of. You want to know, is it school-related stressors? Are they getting bullied at school? Are they not making friends? Are they not doing well in classes? Kind of see, is there any outlying cause to the behaviors that they're exhibiting? Additionally, you want to kind of screen for comorbid conditions. Like I mentioned before, ADHD is one that's high up on the list as far as comorbid conditions, as well as substance use disorder. So being able to ask your patients about that in a confidential manner can play a very vital role in the history-taking part. You also want to kind of assess where the patient is on the learning scale as well. If there's a learning disability there that the patient and the family just doesn't know about, they don't know how to cope with it. And if it's a learning disability, again, you're gonna wanna tailor your treatment plan more towards that. So being able to take a very thorough patient history is vital in how to improve patient outcomes. Now, I know I've mentioned this quite a bit about how treatment plans are kind of tailored to the patient and their families themselves, that not one shoe fits all. And that is very true for just about any diagnoses that a patient can present with. But there is kind of that checklist of a good starting point that people can use for any patient. And a lot of it is trial and error. Did this work? No. Why didn't it work? Maybe we can try this instead. Maybe we can tailor this to that. I think that that's a lot of how you come up with the treatment plan for patients with oppositional defiant disorder or conduct disorder. The management for either of these are very multifaceted. It could be some behavioral education, individual therapy, family-based interventions, parent management training, kind of teaching parents how to cope with when their child is having a temper tantrum, teaching parents strategies to kind of reinforce positive behaviors and manage defiant actions. There's cognitive behavioral therapy. It helps children develop better problem-solving skills and regulate their emotions a little better. If there are some comorbidities that are present, such as ADHD, there are some pharmacological treatment options out there as well that could be explored with the families. And there's also school-based support. A lot of school systems, they could have like group therapies that are offered that the child and parents could kind of participate in. And it honestly can play a very crucial role in addressing academic challenges, getting the child to be more exposed in that academic setting, learning more social skills, how to interact with their peers. What's important is that there is an early intervention and that it is consistent. Kind of parents holding the child accountable, physicians holding parents accountable and bringing child in for evaluations, kind of being monitored, doing progress updates, progress meetings to make sure that the treatment plan is working. If it's not, that there are changes being made to help both the child and the families, and knowing that if it's not working, having an understanding of why, and if it is working, having that understanding as well, in case down the road, if let's say therapy is stopped, and then it's picked back up, you already have your notes of what worked, and why it worked, so that way you have a place to start off from and not having to start off from scratch again. Now, with the newer DSM-5 that was published in 2022, there have been some changes, some things added to overall provide a greater emphasis and on the functional impairment, to provide greater diagnostic criterias, more specifiers to fully understand and kind of categorize how either severe or certain traits that children or adolescents are presenting if they're diagnosed with oppositional defiant disorder or conduct disorder. Some changes with conduct disorder is that there is a new specifier. The specifier is with limited pro-social emotions. So they kind of lack remorse, they lack empathy, they aren't really able to express those types of feelings. Like if they caused physical harm to somebody, they kind of have that nonchalant behavior of, oh, okay, they don't feel bad for hurting them. They don't care that they did, that they don't feel guilty for it. They don't think what they were doing was bad. For oppositional defiant disorder, the symptoms were kind of categorized with emotional and behavioral dimensions. And these changes are just to have a better understanding of both of these diagnoses and just to be able to provide a more thorough understanding and education. So now just kind of going into a very short case example. So a 10-year-old boy with frequent temper tantrum argues with their teachers and defies rules at home. So what is the diagnosis? So they're having very frequent temper tantrums. They seem to be arguing with teachers, defiant at home. They don't seem to be presenting with a lot of symptoms that are outside of societal norms, not really causing a lot of harm to others, crossing boundaries, it sounds like. So this child could be presenting with oppositional defiant disorder. In this case, the patient's defiance and temper tantrums align a lot more with oppositional defiant disorder. So what's the treatment plan? Treatment plan could involve parent training to kind of help manage behaviors at home, individual cognitive behavioral therapy, sitting down with the child, seeing what's going on, what's causing them to throw temper tantrums, are there anything that kind of sets them off that they've noticed, anything that just gets them particularly angry that could be fixed, kind of seeing where the patient's head's at there. And the cognitive behavioral therapy can just help showing patients how to improve their own emotional regulations. And then school collaboration, that could also be part of your plan, to help kind of ensure consistent support throughout the patient's day, from at home to school, and then they have their own kind of tools in their tool belt that they could be taught to use when they're out there in society, when they're hanging out at a friend's house, things like that. But that is the end of my presentation. I hope that this was beneficial, that it touched on the big aspects of oppositional defiant disorder and conduct disorder. The most important takeaway home point for me is being able to recognize symptoms early, starting interventions early, keeping an open line, building a great rapport with your patients, and following with them periodically to overall improve the quality of life, not just for the child or adolescent, but also for the family as well. Family therapy can go a long way, cognitive behavioral therapy, and it all starts with who the family kind of brings the child in to see to help navigate these symptoms, whether that's the therapist, the psychiatrist, family practitioner, school guidance counselor, whoever is that kind of first line. It's important to be able to open up that conversation with the family and kind of get the ball rolling on finding the right treatment plan for them. As I've said many times before, one treatment plan doesn't fit everyone. Being able to be adaptive to family and patient to find exactly what works for them is very important to just improve overall outcome for everyone involved. But that is all that I have for my presentation. I hope you enjoyed it. And on this next slide, these references kind of provided the foundation for the information that I presented to you today. And I encourage further exploration into different literature sources out there if you're really interested in learning more about oppositional defiant disorder and conduct disorder.